Hi, my name is Tara Austin. I am a neuropsychologist and a researcher at the San Diego VA healthcare system. And today I'm going to be talking the second part of our lecture on social determinants of health and brain health. So today we'll be focused on cognitive outcomes and neuropsychology and how social determinants of health impact cognition and cognitive outcomes. So we'll start again with brief definitions that will be helpful for this lecture, and then we'll talk about social determinants of health and how they impact cognition and cognitive performance, and then consideration for neuropsychology as a field and neuropsychologists and those who are interested in the field. What should we be thinking about regarding social determinants of health? So some definitions to start with. Discrimination refers to different treatment of different groups, whether this is based on age, gender, racial, ethnic, religious affiliation, sexual orientation, both at an individual level, so how they're treated by individuals, as well as institutional or structural levels, so the political systems. And this usually takes place in negative, hostile, or injurious treatment of members of rejected groups or members of the minority groups. And then racism is a form of prejudice that includes negative emotional reactions to members of a group, acceptance of negative stereotypes about that group, and racial discrimination or different treatment against individuals. And in some cases, this can lead to violence. And systemic racism is processes and outcomes of racial inequity, inequity in life opportunities and treatments that occur through institutional structures, societal structures, as well as individuals' thoughts, beliefs, and values, and the interactions every day. So I really like this chart by Reyes et al. In their recent article that came out that looked at social determinants of health, as well as many other factors that impact cognition and cognitive performance. So we see over here, social determinants of health got a third of these top factors that impact cognitive performance. So these are, again, shape 30 to 50% of healthcare outcomes, and that includes cognition or cognitive health outcomes. And they often are responsible for disparities or inequities in outcomes and quality and access. So we're going to discuss many of these separately. So we'll kind of separate out again education versus neighborhood. However, many of them are very connected. So income is very related to access to education or access to food and even access to a neighborhood that has the resources. Additionally, discrimination and racism might reduce some of those resources. So some of the redlining policies have led to an inequity of what neighborhoods people are able to live in. And often minority populations or minority groups are in areas that have many fewer resources. And then we call these modifiable factors. However, it's important to remember that the social determinants of health can put limitations on the choices individuals are able to make. So physical activity requires a place to be physically active in. If you're in high density housing with very little room on your own, in an area where it is not safe to exercise outside, there are few pedestrian paths, few places to walk. If you do not have the finances to be able to go to a gym, that limits what activity could be done. Additionally, living in a food desert reduces your ability to buy nutritious, high-density food. Neighborhood can also impact sleep, pain, and then we see that racism, discrimination can impact social engagement, can impact stress and individual experiences. So they're all very related. And if I drew arrows connecting everything, then I felt connected to everything, we wouldn't see any of the words through all of the layers because social determinants of health really do impact so many areas of our life. So we're going to talk about the social determinants of health separately with the education of healthcare outcomes, because since this is related to cognition, healthcare is popping up in almost all of these slides. So to first start by education, education quality and access, or how much someone is able to learn in school correlates very highly with how they will perform on our neuropsychological tests. Education is a protective factor for physical and cognitive health. Completing at least some college is associated with lower risk of chronic disease. Higher education is associated with lower 5-year mortality rates and the least morbidity from chronic illnesses. And education is also protective against future decline and dementia, including Alzheimer's disease. We talked about this in the previous slide, but it's important to think not just about quantity, but also about quality. And in some cases, quality can be more important than quantity, because if someone is attending 12 years of school, but had very, very poor quality, not a lot of instruction or access to materials needed, that impacts learning. So education quality, we know, varies across groups, with more minority groups, ethno-racial minorities, immigrant, and lower SES groups having lower quality in the education they are able to access. This can look like fewer credentialed teachers, higher dropouts, lower college graduation rates, lower literacy rates, less materials. And then schools that have more minority groups also get less money per pupil, which is needed to pay teachers, or is needed to be able to recruit teachers with the highest credentialing or the training. It's needed to buy books. It's needed to employ more staff to have lower teacher to student ratios. So this is very important for that quality aspect. And then our next one, social determinant of health, is social economic status, and related to economic functioning. And so we're going to be kind of talking a lot about poverty in this slide. So social and economic factors explain 5 to 30% of differences in cognitive performance. This is noted in domains including language, executive functioning, and memory. And childhood SES explains 60% more of the difference in academic achievement than genetics. So this goes to show that this economic component buys a lot of the resources that are needed in order to have optimal performance and optimal achievement. So lower SES is linked to reduced cortical thickness or thinner brain regions in some areas that are really important for memory and decision making. Earlier poverty is more associated with this, particularly because the brain is still developing at this time. So we see that there are environmental factors that are often linked to this that contribute to differences in cognitive ability. So it's not that these groups are biologically or genetically different. However, their experiences and their access to services and the quality of services all can impact this. So SES is associated with the complexity of language and the amount of language that children hear at home. So parents that are having to work lots to provide for children, or children that are in daycare settings with lower provider to child ratio, that impacts heard language, and that is very important for brain development. Additionally, lower SES and poverty is associated with higher levels of stress in everyday experiences. So this can be more chaotic living environments. This can be a lack of services that increase stress, and then that impacts the functioning of key brain areas that are important for memory and problem solving. So stressed brains don't function as well as not stressed brains. And then there is less access to important things that we know is good for our brains, healthcare, healthy food, as well as cognitively enriching environments, or environments where someone is able to learn and grow and has the free time and the mental space to be able to learn and pursue things they're interested in. Our next social determinant of health we'll talk about is social and community factors. So there are persistent health disparities in the US based on race, ethnicity, gender identity, and sexual orientation. Healthcare and healthcare disparities exist between whites and minoritized ethnic groups, with many of these linked to higher rates of neurological diseases. Older sexual minority adults also face disparities, exhibiting higher rates of disability, higher rates of smoking, and worse mental health outcomes than heterosexual peers due to, again, that stress and discrimination. And the burden of Alzheimer's disease and related dementias is heaviest on minority communities, including African Americans, Alaskan Natives, Blacks, and Latinx population. So all of these, again, occur secondary to the environments and the ability to have access to services. So discrimination and racism are big negative factors for brain development. So it impacts cognitive functioning through increased stress and inflammation, which are not good for current or future brain functioning. Additionally, there are barriers to healthcare for many groups. So less preventable care, difficulties for less insurance coverage, limited mental health services. Additionally, that quality is important. Is an individual able to receive affirming care or have any of those cultural or linguistic factors integrated into their treatment, or access to a healthcare provider who is able to communicate effectively with them? Additionally, the research that we base care on has not been done on a very representative sample. So when we look at some of these genetic data sets, we use these to kind of build models on that we then will test treatments on in our clinical research, which then will get passed on to patients through the treatments we have available. And several of the genetic large data sets, between 80 and 90%, are white non-Hispanic individuals, despite that group being less than 12% of the world. So when we're creating models that are built on the experience of 12%, this might not translate to others. Additionally, there is history of exploitation in clinical research of certain groups. And so advocacy is needed, as well as transparency, to make sure that we are including as many individuals in research as we can, and doing so in a fair, transparent way. To have groups that have had exploitation in the past, we need to work to build that trust. Additionally, underrepresentation in healthcare professions. When we do not have a percentage of the population involved in creating the research, in examining treatments and looking at barriers, we're not going to have a good understanding of many factors that individuals experience. And so we need representation in the healthcare profession as well. And to that clinical research, again, exploitative past research with marginalized populations have led to mistrust of healthcare professions and reluctance to seek treatment. And that's up to kind of clinical researchers and healthcare as a field to work towards gaining this trust again. And then our last social determinants of health we'll be talking about today, neighborhood. So neighborhood disadvantaged, or areas that have less services, higher pollution, less green space, pedestrian walkways, that's related to or linked to lower current cognitive performance, as well as increased risk of Alzheimer's disease and dementia, as well as neurological disorders, including epilepsy, and cardiovascular outcomes and stroke. So these areas have more toxin, pollution, and overcrowding, which are not great for brain development. And this is over and beyond what we talked about in the slide on economic disadvantage. Additionally, there's high levels of neurotoxins, including mercury and lead in some of these areas, and there's no safe level of exposure to these neurotoxins, so it's very important to pay attention. And then additionally, there's been discriminatory housing policies. So certain groups are in areas that have reduced resources, increased stress, and this cumulatively can lead to lower cognitive performance. Additionally, we've been focusing on kind of urban environments and what this might look like, but it's important to look at rural neighborhoods and rural areas. So there can be advantages to some of these areas, but as well as disadvantage. So there can be lower rates of some disorders in rural areas. It can be protective. However, this is offset by lack of resources. So one example is there are lower cancer rates in several rural areas, however, higher death rates due to delayed treatment and lack of resources. So now we've talked about how the social determinants of health impact cognition and what we might see. This kind of leads us to our next step, which is looking at how we should be thinking about these cognitive differences as a field. I really like Fuji's 2023 article that talks about some practical steps neuropsychologists and students interested in neuropsychology can take to advance our field and advance health equity in brain health. The first is important to understand intersectionality, which is this first bullet point. So this is how class, race, gender, migration status, age, sexuality, disability, religious affiliation, all of these experiences we have overlap, and they're unique to us. And some of these carry discrimination, and some of these carry areas of privilege. And so it's important to not just kind of put someone in a box of one of these, but to consider their full experience, which in some case they may have areas of privilege that help, and in other cases they may have multiple areas of discrimination, which could produce even less access to some of these things we've discussed. So it's important to be familiar with this literature on intersectionality, as well as cultural neuroscience, which we've kind of very briefly talked about in this lecture. Additionally, it's important to have more recruitment and training of minority students and faculty. So they are underrepresented in our field. And in order to have the best research, the best equity and outcomes, we need diversity of voices and experiences. Additionally, we need to recognize the biases in both the field in terms of our testing and the limitations we have and the instruments we have, as well as our own biases that we carry and experience. And so this is important to provide culturally informed, linguistically appropriate assessments. So most neuropsychological tests were developed or normed using non-Hispanic, white, English-speaking, high SES groups that do not reflect the majority of the world. In order to try and account for some of this, the demographically corrected norms or demographically adjusted norms can look at age, race, education, gender, in order to improve diagnostic precision. However, this is very important for us as a field to be able to make sure that we are contextualizing this and we are appropriately using these, particularly racial disparities that are correct in some of these norms, are being corrected because they're a proxy for social determinants of health, as we talked about in the very beginning of presentation one, that we have inequalities in access, and that minority groups on that health gradient often have the lower outcome due to lack of resources. So racial disparities in cognitive performance stem from these environmental factors that we've talked about, these opportunities, the access, the quality, as well as the fact that our tests are not perfect and that they were largely created with a small group that does not represent many areas. And this is not related to genetic or biological predispositions. And then our last slide, important to keep conducting this research. So looking at these social determinants of health, including the effects of discrimination, and looking at the disparities we talked about on the future slide, and making sure we contextualize everything in a biopsychosocial model. Looking at kind of minority stress, looking at the impact of racism, that the difference we're seeing are secondary to the experiences and the opportunities that are limited for some groups. It also is important for us as a field and individuals to advocate against institutional discrimination, against individual discrimination, to try and create equity and move our field toward equity. To kind of go back to the beginning where we started in presentation one, I wanted to review this quote from Dr. Cooper, that what we learned about in these two lectures, or these social determinants of health, are the first step to be able to move us from health disparities to health equity. And the better we understand these factors, what are contributing to them, and ways they can be improved, the more we are going to be able to move to more equity in brain health, which is our ultimate goal as a field and also as practitioners and students and those interested.